Well, hello everybody, and good morning, good afternoon, and good evening, depending on where you are. The words of my mentor, Dr. Tedros from the World Health Organization, he says that every time that they have those meetings there. Good morning, good afternoon, and good evening. So whatever it happens to be in your neck of the woods today, thanks for joining us. Today, I have a couple of my friends today. I have Joanne Spethman with us, and I have Sandy Giangreco Brown, who is no stranger to any of you, right? Sandy, you have been so busy lately.
It's been a little crazy, but so much fun. And it's been great to be out. I love our conference seasons. I always love it when we're out and about, and especially after COVID and after we were virtual for so long. It's been so great to actually get out to see people. And it was great to see you, Christine, a couple weeks ago and actually see people in person again.
No, we were at the Health Advocate Summit in New Orleans. I still, every time I go to that summit, Sandy, I learn so much about how we can really help patients out. And one of the things I think that we talked about with some of the vendors that were there is making sure that the claims are clean claims and that they're getting either paid properly or rightly so denied properly. And sometimes that has to do with the diagnosis code, right? So it kind of loops into what we're going to talk about today on National Chai Day and National Pecan or Pecan Cookie Day. I just like cookies, period. So it doesn't really matter what's in it. I'll eat the kitchen sink cookies.
Those are my favorite too.
Yeah. Ladies, we're going to talk about section 2 and 3 of the ICD-10 guidelines. And these guidelines often, I get a lot of questions from students, and they ask us about how we report specific conditions in a inpatient setting, right? How does that work on an inpatient setting? And so, and also, what is the uniformed hospital discharge data set that is referenced in section 2 here? So I don't know if any of you could give us a little synopsis of the differences between inpatient coding from a diagnosis perspective versus the prophy or the outpatient side of coding.
Well, I can take the inpatient side. So the principal diagnosis, for example, is defined by the UHDDS, the data set, as the condition established after study to be chiefly responsible for occasioning the patient's admission to the hospital. So the phrase after study is really important to remember here because the principal diagnosis may not even be apparent until after all the workup is completed and response to treatment is noted. And this may take several days. So additionally, at the end of the inpatient stay, the physician may not have a confirmed diagnosis. And in this case, coding rules state that he may document a suspected diagnosis. So I think, we're dealing with two different timelines as far as, when your patients are coming in versus when inpatients are coming in. And for the principal diagnosis, I feel that's the inpatient side of it.
Right, because I think on the outpatient side of it, or maybe in the office, or a lot of those pro fees, we've got specific guidance that says, hey, if you haven't figured it out yet, tell us what the signs and symptoms are that you're focusing on today. And from an inpatient perspective, we're actually told opposite. We're told no signs and symptoms, right? Tell us what you think it is, and then, we can always update that information, right?
Yes.
What about when we go ahead, Sandy?
No, I was just going to say, and I think one thing that could be slightly different is that, and one thing that the coders want to think about, and one way that I always keep it straight in my mind, is that the hospitals are going to get paid for that work that they're doing of working up that patient until, like Joni said, that workup, right? So when that physician is still trying to figure out, or that provider is still trying to figure out what is going on with this patient. And like Joni said, it can take several days. So that's something that during that time frame that the hospital can get paid for that. And so that's different than if we were to be coding for the physician their services, or if that patient were to be an outpatient or an observation and they're not an inpatient. I just want to kind of carve that out a little bit.
Mm-hmm.
And we would have to go back to the guidelines of coding the signs and symptoms, or what they are definitive about, anything that we knew definitively.
So you could have a different diagnosis for observation, and then when that patient is admitted, that diagnosis could change into the principal diagnosis. So I think that's important to realize, is because from the E&M side of it, we don't really count what happened prior to the admission. If the end of the day they end up admitted, then it's admitted. But I don't think a lot of people realize that they could have been in an observation status from the ED to observation to inpatient by the end of the day, and how that diagnosis could flip depending upon where they are in the course of their trip in the hospital setting, ED or observation or inpatient. So definitely challenging there.
Yes. And one thing I just want to call out too is that you also want to be cognizant of that when you are coding, to just code what you know at that time. So if you have a patient who, for instance, in the middle of their stay, you know this, that's what you should be coding. But if it's not that, like Joni said, when that provider's working that patient up and they don't know until, day 10 that they have sepsis, don't code the sepsis on day 5 if you don't know definitively. Only code what you know, and don't go retroactive, because that can be detrimental to that provider, because the documentation, especially on for the pro fee charges, may not support it. And on the outpatient side as well, if they were still on an outpatient or in an observation status as well.
What about when they're in an outpatient surgery, but then they have to get admitted? So, for example, my sister had outpatient surgery, but she had so much postoperative pain that they couldn't manage it. And they admitted her to the hospital, and she was there for a couple of days for pain management due to the surgery. So how would we work that out? Because the surgery diagnosis isn't necessarily the same diagnosis for the admission.
Do you want to?
You want that, Joni?
Okay. I know.
We have 3 people here, so it changes the dynamic. But I thought it was awesome. I thought for this topic that we just needed to bring out all the big guns.
Yeah. So in my mind, from that, we want to make sure that we capture, the fact that this patient went from an observation to an inpatient, and also thinking about why did they go. And I know Joni will really, hit on that from that inpatient perspective. And we also want to think about, do we have that order? I know that is really important on the hospital side. We have to make sure that we have the medical necessity as well. Do we have the order and the information to be able to support why that patient needed to stay? For instance, in your sister's case, the fact that she needed to be in until they could get her post-op pain under control. And then what did they need to do? Patients also need to make sure that not only is their pain under control, but they also need to make sure that they're eating and they're pooping and peeing and all those things. Make sure things are working.
That is the one thing that they always, every hospitalization I've ever had, have you gone to the bathroom and have you moved your bowels? Like that is
Yes.
number, and waking you up in the middle of the night. Would you like something to sleep? Well,
Now I would.
exactly.
If you're offering, yes.
Yeah.
Now, you talked about, Joni, you talked about the principal diagnosis. What about all the other things that still need to be taken care of while the patient's in the hospital? Like their high blood pressure doesn't go away or their diabetes doesn't go away because they're there for a surgical intervention. How does that work into our coding from an inpatient perspective?
So, reporting additional diagnoses is what you're referring to, and
Mm-hmm.
anything they have a list in the guidelines of that anything that requires clinical evaluation, therapeutic treatment, diagnostic procedures, extended length of stay, increased nursing care and or monitoring. Uh, these are criteria that are established to in reporting a secondary or an additional diagnosis. So if it meets one of those guidelines, then it's reportable. So, and the hypertension, it's expanded so much between the different kinds and crisis and urgency, and there's so much specificity that goes along with just that example. And querying is a huge part of inpatient, as you know, and getting that specificity through queries is the best method, I guess you could say.
And I think that people should be,
go ahead.
We should remind people that the query is so important. I know that as a child, my parents would often tell me, mind your business. Don't ask so many questions. I was that girl. I was the why girl. Well, why? Right? I think that it is important for us to know that we are only coders. There is honestly a limit to what we're supposed to know. And when something isn't clear in documentation, and not just clear for us, because oftentimes we develop these relationships with our providers and we know what they mean, but remember that we're not going to be there when a document is reviewed from another party, whether it's for continuity of care, that specialist, or if the legal team gets involved, or if the payer wants to see it. We're not there to hold that hand and to say, no, wait a minute, he meant to say. So I think coders need to become more and more comfortable asking those questions. It has no reflection on you or your knowledge or what you're talking about. Often I hear, well, I should have known. No. If it's not clear in documentation, just remember, you might be asking the query, maybe not even for your own self, but because a payer is going to look at this, or legal, or another specialist, and it's vague, right? And we do need to ask those queries. So I want to encourage everybody out there to keep asking questions, get that definitive answer, and then get your doctor to add the addendum to it so that it's not a statement that happened, but it's actually added to the medical record, that clarity.
Yeah, there's a difference between asking for clarification versus asking them for a new diagnosis. You're just asking for more clarification of something that's already been documented, and that's important too. So it's not leading. So
there is a guideline in here in section 3, and it talks about abnormal findings. And this one I find very interesting because a lot of hospitals have policies on chest x-rays. And often I'll see, I also work in a lot of risk adjustment. And so, when you're going through and you're data mining and risk adjustment, you review a lot of hospital records. And often I'll see that a 76-year-old patient has arteriosclerosis of the aorta. That comes up on the chest x-ray. Really didn't have anything to do with the reason that they were in the hospital, but there is an abnormal finding of some sort. How do we relate to that scenario?
So, I guess in the guideline, it talks about the findings are outside the normal range and the provider has ordered other tests to evaluate the condition, it's appropriate to ask the provider whether the abnormal findings, should be added, or are they, indicative of a certain diagnosis, like the criteria for sepsis, for example, the white blood cell count, the, temperature, all of that. So that's, one way that in an inpatient with abnormal findings, it's mostly used for their queries, actually, because you want to list
I
those.
was about to say.
So it's a big part of the query.
That's another great area that we can ask. Again, we're not double checking our doctor's work, but we're simply asking, is there any clinical relevance to this that you might act on it? Does that white blood cell count cause suspicion for you? Did you order an IV of antibiotics because you thought that, right? Kind of match it all together for us, dumb it down for the coder per se.
Right. Or validate, the pathology findings, and, that's important when you're dealing with really abnormal findings of cancer and other serious things.
Well, and I think it's important too to think about, and I know it speaks to this and you mentioned this, Joni, about those things that may need further treatment in the future. So maybe we're not going to address that while the patient's inpatient now, because we're just trying to deal with their pneumonia or their sepsis or whatever. But after they are discharged and they're stable, then maybe we want them to come back, or maybe we're going to refer them to a hematologist or, someone else, to be able to consult on this patient and decide what may be going on with them. So I think that that's important too. And I think too often coders may kind of miss the boat on that. I know I see that sometimes where I'm like, no, I feel like you need to show that future care. And I've seen that. I used to see that when I did some, and it was on babies or something. So
yeah,
I just feel like that's important.
That's a great point, Sandy, and that's so common when you'll see documentation that they're going to address it later, and you think, oh, then I don't need to, address it here. And you're right; it is being addressed here because they they monitored and did enough of a workup to know they need further care. So that's excellent.
Right. There was that clinical evaluation.
That's right.
Absolutely. I just think it's so interesting that there's so much more that we have to consider from an inpatient perspective, not just the diagnosis codes, that principal diagnosis, but the other diagnosis codes as well, or the first listed diagnosis. What's the difference between the first listed diagnosis and the principal diagnosis?
Well, your first listed is going to be your admitting diagnosis. Is that what you're referring to?
Yes, the admitting diagnosis versus the principal diagnosis.
Right. Their chief complaint, what they came in with, and obviously your principal is going to be after study. It's going to be a more definitive diagnosis, and it could even be a symptom, of what you're coming in with.
Right, but that's great. The admitting can be a symptom, but the principal can't be a symptom.
Well, it shouldn't be. I mean, we don't want it to be.
Right.
That's the goal.
I often think, that sometimes the symptoms themselves probably don't warrant an inpatient stay. And that's another thing. I don't know that if you're on the pro-fee side of coding, if you're really strong and understand that from an inpatient perspective, there are certain diagnoses, there are certain levels of acuity that support an inpatient visit. So it's not that any doctor can at any time say, well, I'm going to admit them. And that's often a misconception. I've been telling my friends, I've been watching Grey's Anatomy, the whole series over again. Boy, there's a lot of episodes there. And some of them I don't remember that well, but I noticed in a few episodes that they kind of manipulate the circumstance to get somebody admitted. And in real life, that would never happen because we have those criterias for admission that need to be met. So just so that coders understand that they're not anything can get an admission into a facility.
Correct.
Mm-hmm.
Yeah, and that's why sometimes on the physician side, you may hear that a patient was admitted or the physician admitted them, but then it's flipped back to an observation or, things like that because that patient did not meet criteria. And that's exactly the situation. Happens often on the weekends and in the evenings when, especially if you don't have providers who have been educated well. If you have a robust CDI program and such, and a UR program, a utilization review or utilization management program, where they're doing a lot of education with the providers, a lot of times they'll know, okay, this is going to meet, this is not. But sometimes they won't know. And then sometimes the darn picky insurance companies too will say, well, we don't feel like it meets criteria either, but there is.
Right, like unspecified arrhythmia.
Yeah.
Okay, but if you can't do an EKG and see on EKG what type of arrhythmia is that? Is it AFib? Is it SVT? Is it what is that arrhythmia? I mean, I can understand it from a payer's perspective where they could say unspecified arrhythmia. Okay.
Mm-hmm.
We're not going to pay for a hospitalization for that.
Yeah, and then there's the whole, could this have been treated at home? I mean,
right.
Did they need special equipment? Did they need, what resources were necessary?
Yeah. Yeah. Or could it be that they could be outpatient or observation? Could we have that patient come in even for IV antibiotics or something? And, Joni and I were just talking about social determinants of health and stuff over the weekend. And we're both very passionate about that. And, it kind of brought up something that I remember Dr. Levy from the AMA talking about a patient being homeless. That complicates a situation where if, I were needing IV antibiotics, well, I can be discharged home. I just come in twice a day to get my IV antibiotics. Life is good, da, da, da. But if we have a homeless patient who doesn't have a secure place to live and they don't have that ability to come in and get the IV antibiotics, well, then that's why we now are seeing that is a CC, right, Joni? That now they can come in and get that. And that really shows that necessity. So I think it's cool now that we're being able to see these things that are impacting the care of the patient and potentially impacting them.
Well, I know that we had talked about social determinants of health, but it wasn't until COVID hit that we were really smacked in the face with it. Honestly, we heard more about patients that they were at home alone, or they were in a nursing facility where they couldn't leave and no one could come in. And we saw a lot of these unique situations that we'd never thought about before that were truly brought some of this to life. Or yes, maybe this is something that could have been treated at home, but they don't have support to come and be with them, or they don't, it's things like that that we really need to think about when we talk about the admission or the observation. And I think it's also important to remind people that observation can take place over the course of a couple of days. It's not that you only go for observation for a few hours. You could really be in an observation status for 2 or 3 days in a hospital. Again, not meeting the criteria to become admitted, right? But being needing more than what the emergency department can give, what that intended stay at the emergency department is. So really important for us to know those things about our patients and start becoming more and more conscious of that.
Yes. And I know one of the things too, Christine, that you had kind of mentioned was thinking about the rehab stays. And I know that was something recently when I was doing some education and an audit. Someone didn't realize that we had specific codes for the different types of rehab that a patient could be having, and that we could be really specific to that, and they didn't realize that. So it's again that specificity that we want to try to be able to code when we know that and when we have that. And of course, we want our documentation to support that. But that is something. And then thinking about that as we have that, and then adding in any other previous conditions that could be applicable as well. And I don't know, Joni, if you want to hit that one too from an inpatient perspective too. I know we've kind of talked about that, but
what was the question?
About previous conditions and
So, chronic conditions, comorbidities. Yes. I had an example that just recently where it said history of CHF in the ED and then nowhere else. And there was no medication, monitoring, nothing. And so obviously you're going to query probably in that case, but you want to make sure that there's something being done on some level. Are they still being treated?
History of CHF. You mean they found a cure?
Exactly. And so it was just very, I don't know, it's vague, but it's also, it's not consistent. I mean, you can't emphasize enough how consistent the documentation needs to be. And I do see that where the ED is saying one thing, and then it's like you're meeting a new patient and once they're admitted. So it can get confusing for sure. It's mainly, you want to look for, are they mentioning it, monitoring it, treating it, all the things that go along with choosing an additional diagnosis.
Absolutely. And don't forget that if you are admitted for rehab, we need to be very specific in what we're rehabbing at the time. My go-to joke is, it's not a joke, it's a serious condition, but I do kind of make light of the CVA. By the time that they go to rehab, they're no longer in the middle of an acute CVA. That has passed now. They're stable enough to leave the inpatient facility, and they're going now to rehab for that. And I think we need to remember as coders that we need to use the most specific code for that admission into the rehab there, which might be that this is an old CVA or post CVA with hemiparesis, and we're working on hemiparesis or dysphagia or whatever that condition is that we're in rehab to try to gain or regain some of that use from the stroke. So just to remember, always be thinking about what is actively happening at today's encounter, because it could be very different depending upon whether we're the ED, observation, inpatient, post-inpatient rehab, any of those locations there. And the rules change.
Yeah. And I was just going to mention, in the skilled nursing facilities and in the long-term care, the SMRCs are now doing some audits, and they're doing the TPEs where they're just looking at 5 records, but they're looking at those and trying to give feedback. And I think part of it is because of those history of, we're curing CHF and things like that miraculously.
You discharge them in the middle of a stroke to the nursing home? How could you?
And no sequela, but it's those sorts of things that we need to remember. So I think we're going to see more of that information come out, and see that TPE information out for everyone to be able to learn from. So
I call those the hot sheets. When we start to see the reports from the OIG, or we see the results from RAC audits, TPE audits, and all of that is out there and it's published. All you need to do is either look at your MAC or look at CMS or look at the OIG, and all of those reports are there for us. And if I put my little compliance hat on, I'll tell you that the best type of defense is to be proactive and educate yourself and see what other people, the recommendations that have been made from the audit findings, and how do you implement those recommendations into your organization so that you never find yourself on the nervous side of an audit. Not that you're never going to find yourself on an audit, but there are times I have certain practices that they do their own internal monitoring and auditing, and they look at these guidelines and they look to see if there's any opportunity to improve. And then when the audit does come in, they're like, we've got this. We did one internally. All of our documentation is on par. We even send them our report of findings because we did so great, right? So it can also help you out in the long run, education, knowledge. Well, ladies, we are at time. Can you believe it? Again, I thought it was amazing. It was amazing. We talked so much, and it has really been a lot of fun. I want to thank Joanne Spethman. I want to thank Sandy Giangreco Brown for joining me today. And we have one more episode to wrap up our guidelines. Right now, I think here in the next couple of days, I've been doing a lot of presentations on the 2024 ICD-10 codes. So grab yourself a webinar, find us. You can go to our website. You can find where our next presentation is. Most of them are with AAPC chapters, which give you CEUs if you need them. And you'll get up to date on the information that's coming to us, in less than 2 weeks. We're going to be in those new ICD-10 codes and guidelines. So
come and click.
Yeah. Thanks so much, ladies. This has been an absolute pleasure. Enjoy your chai today and enjoy your pecan cookies.
Yes. Thank you.
Thank you.
Thanks for watching.